Hello everyone, we have a 45-year-old man. He come for evaluation of chronic diarrhea. He lost good amount of weight in last 1 year. Fecal fat content is very high. Patient is given 25 gram of oral D-xylose solution and his urinary excretion of D-xylose is 5 hours is 1.2 gram. After 4 weeks of treatment with rifaximin, the test is repeated. The urinary excretion now at 5 hours is 1.3 gram. It is almost same as was previously. There is not much of the differences there. Most likely diagnosis of this patient is, well, the answer to this question is celiac disease. Why? The patient has chronic diarrhea, steatorrhea, fecal fat content is 10 gram as normal is less than 6 gram. Weight loss is there for the past 1 year, suggesting malabsorption. It's a common cause of malabsorption. It is characterized by atrophy of the intestinal villi in the proximal small bowel due to exposure to gluten-containing products. Now, what happened in this patient? As I told you, there is a atrophy of the villi. This is normal villi. You can see normal villi. And here all are atrophied. The classical finding. Subtotal villus atrophy in celiac disease, blunting of villi B, and crypt hyperplasia. You can see crypt hyperplasia are there. Okay. And there are infiltration of lymphocytes. You can see a lot of lymphocytes are there in this. But this is virtually one of the classical, just see finger-like projection and now totally flat is there. It's common in North Europe descent people. It's bimodal presentation in infancy or 50 to 60 years. Now there are few questions for you. Stop the video, write down the answer. Which are gluten-containing food items? Celiac disease is associated with HLA. Which antibody are seen and why D-xylose test is done in this patient? Stop the video, write down the answer. Gluten-containing food are, the mnemonic is bro. Barley, mnemonic is bro. B for barley. Rye. Oat. Wheat. They are the 4 gluten-containing food. Celiac disease is associated with which HLA? DQ2, DQ8. And which antibody? Anti-tissue transglutaminase, what we call as anti-TTG. Why D-xylose test is done? It is a monosaccharide that can be absorbed in the proximal small intestine without degradation by pancreatic or brush border enzymes. Subsequently excreted in the urine. In D-xylose test, patient is given an oral dose of D-xylose and subsequent assay of urine or venous blood is done, usually by urine. Patient with proximal small intestinal mucosal disease like celiac disease cannot absorb D-xylose. In the intestine and urinary and venous D-xylose level will be low in these cases. By contrast, patients with malabsorption due to enzyme deficiencies like chronic pancreatitis, they will have normal absorption of D-xylose. A false positive D-xylose test decreased urinary excretion of D-xylose present with normal mucosal absorption can be seen with delayed gastric emptying and impaired glomerular filtration, but they are very uncommon. But now our patient has low urinary excretion So that means there is a reduced mucosal absorption of these xylose, which is going in favor of celiac disease. What about bacterial overgrowth? This is characterized by alteration of the flora of the small intestine, usually due to abnormal intestinal anatomy or motility. A false positive D-xylose test can be seen in SIBO due to bacterial fermentation or ingested D-xylose dose before it can be absorbed. So SIBO is unlikely in this case, as treatment with rifaximin did not significantly change the D-xylose. This antibiotic was given if it was due to bacterial overgrowth that will take care of the bacteria, but that has nothing. Even despite giving rifaximin, there was no change. D-xylose level was still low in urine. Lactose intolerance, typically diarrhea, abdominal pain, and flatulence taking milk or milk-containing products. Fecal fat and absorption of D-xylose will be normal in lactose intolerance. It has nothing to do with that. Terminal ileal disease characterized by transmural inflammation of the GI tract, most commonly in the distal ileum. Patient may have steatorrhea due to abnormal absorption of the bile salt in the distal ileum. And D-xylose is absorbed in proximal small bowel, so it will not be affected. But now I have a question for you. Stop the video. In terminal ileum disease, which vitamin level will be reduced? Stop the video. Write down the answer. Well, the answer is B12 because B12 is also absorbed in the terminal ileum. Golden line to remember, D-xylose is a monosaccharide that can be absorbed in the proximal small intestine without degradation by pancreatic or brush border enzyme. Patient with small intestine mucosal disease will have impaired absorption of D-xylose. Patient with malabsorption due to enzyme deficiency will have normal absorption of D-xylose. Thank you very much.